Imagine you're standing at the foot of a hospital bed, examining a patient who feels a strange tingling in their feet. If you ask about their recent history, it might vaguely remember a minor stomach bug from about 2 weeks ago, an infection they've already forgotten. Right now, their primary complaint is sensory. They describe a creeping numbness, a sensation of pins and needles that started in their toes and is slowly working its way up their lower legs. But this doesn't stay a sensory issue. You check on them 3 days later, and the tingling has been replaced by symmetric, ascending muscle weakness. Both of their legs are losing power at the exact same rate. By this point, they can't even climb a flight of stairs. This leads to the critical bedside test. You tap their knees with a reflex hammer, checking their deep tendon reflexes. The response is severely diminished or absent, a clinical finding known as areflexia. This specific triad, the preceding mild infection, the symmetric ascending weakness, and the absent reflexes, points clearly to a single diagnosis, Guillain-Barré syndrome. The biological paradox of Guillain-Barré is that the patient's immune system functioned exactly as it was supposed to. It successfully hunted down and defeated that minor stomach bug. But instead of powering down, the cellular defense system misfires and attacks the patient's anatomy. The original pathogen is long gone, leaving no active infection in the nervous system. The weakness results from the body's autoimmune destruction of its own myelin sheath, the fatty outer insulation that allows electrical signals to travel along peripheral nerves. The terror of this disease lies entirely in a case of molecular mistaken identity. A routine, highly effective immune response accidentally turns the body's own defense mechanisms against its anatomical wiring. The mechanism driving this autoimmune attack is a phenomenon called molecular mimicry. Consider the gastrointestinal bacterium Campylobacter jejuni, one of the most common triggers for the disease. The exterior of this pathogen is coated in specific surface sugars with a distinct geometric structure. Now look at a healthy peripheral nerve. Embedded within the myelin sheath are fatty molecules called gangliosides, which help maintain the nerve's structure and function. The problem is that the surface sugars on the bacteria and the gangliosides in the nerve insulation are virtually identical in their molecular structure. When the body builds antibodies to fight the bacterial infection, those antibodies cannot distinguish between the two identical structures. They cross-react. They lock onto the nerve's gangliosides, stripping away the insulation and short-circuiting the electrical signals required for muscle movement. To confirm this is happening, clinicians rely on a lumbar puncture. In classic Guillain-Barré, the spinal fluid analysis reveals an elevated protein level alongside a perfectly normal white blood cell count, proving there is nerve inflammation but no active infection. Because this is an antibody-driven disease, the two mainstay treatments are intravenous immunoglobulin, or IVIG, and plasmapheresis. Neither of these therapies fights a pathogen. IVIG infuses massive quantities of donor antibodies to dilute and modulate the patient's own rogue immune response, while plasmapheresis physically filters the patient's blood plasma to remove the attacking antibodies directly. For most of modern medical history, Guillain-Barré syndrome was understood strictly as a rare, highly specific biological accident. A single public health decision in the 1970s moved this obscure diagnosis to the center of a national crisis. In early February 1976, Private David Lewis collapsed during a forced march at Fort Dix, New Jersey. Within hours, he died of pneumonia caused by a virus related to the deadliest pathogen in modern history. When CDC laboratories analyzed the virus that killed him, they identified a novel swine-origin H1N1 influenza strain. That genetic designation carried enormous weight. The virus resembled the strain responsible for the 1918 influenza pandemic, an outbreak that killed an estimated 50 to 100 million people and remained the reference point for every public health fear. Further testing at Fort Dix revealed that roughly 200 other soldiers on the base already carried antibodies for this novel virus. This proved that rapid person-to-person spread was occurring within the confined population. Put yourself in the position of Dr. David Sencer, the director of the CDC. You are staring down the very real prospect that a virus resembling history's deadliest pathogen has just reappeared. Censor recommended what no American health official had recommended before: a mass vaccination of the entire population before the virus could spread beyond a single army base. Given the data in early 1976, the recommendation followed a clear logic, balancing the weight of historical precedent against absolute biological uncertainty. President Gerald Ford accepted the unanimous recommendation of his scientific advisors, publicly endorsing a national immunization program fueled by $135 million in emergency congressional funding. The logistical rollout was staggering. Vaccinations began on October 1st, utilizing compressed air injection guns to maximize speed. Within weeks, approximately 40 million Americans had been inoculated. But by late November, a crisis emerged. The CDC began receiving scattered reports of Guillain-Barré syndrome in patients who had recently received the swine flu shot. This presented a genuine epidemiological dilemma. Guillain-Barré occurs at a natural background rate in the population, roughly 1 to 2 cases per 100,000 people every year, completely independent of any vaccination. How do you mathematically prove if a rare disease appearing after an injection is actually caused by the drug, or if it's merely a tragic coincidence? This graph shows the active surveillance data collected in Michigan that finally answered the question. The incidence in unvaccinated adults was 0.36 cases per million person weeks. By contrast, the incidence in vaccinated adults jumped to 2.31. Translating that statistical jump into an attributable risk, it meant there was roughly 1 additional case of Guillain-Barré for every 100,000 people vaccinated. That excess risk is small in absolute terms, but when you apply it to a scale of 40 million people, a minor statistical anomaly becomes an undeniable, measurable harm caused by the medical intervention itself. On December 16, 1976, facing this confirmed safety signal, Dr. Censor officially suspended the National Influenza Immunization Program. The final toll attributed approximately 450 cases of vaccine-associated Guillain-Barré syndrome to a program built to stop a pandemic that never materialized outside Fort Dix. The political fallout was heavy. The press condemned the program, and the new Secretary of Health, Education, and Welfare dismissed Censor from his position as CDC director on live television. The 1976 swine flu affair highlights a harsh asymmetry in public health. An intervention that perfectly prevents a catastrophic outbreak leaves no visible evidence of its success. It registers only as a non-event. Public institutions are judged by the visible harms they cause. They are rarely forgiven for the invisible deaths they prevent. The modern infrastructure health officials use to track vaccine safety today, like the National Vaccine Adverse Event Reporting System, was built directly because of how slowly the Guillain-Barré signal was caught in 1976. Every seasonal influenza vaccine administered in the United States still carries a permanent warning label regarding an elevated risk of the syndrome, and the pattern continues to repeat. In 2023 and 2024, newly approved vaccines against respiratory syncytial virus generated their own small but statistically detectable signal of increased Guillain-Barré cases in post-marketing surveillance. Population-level medicine operates under a persistent tension. Delivering any biological intervention to tens of millions of people inevitably results in rare harms. The instruments for detecting those harms have simply improved. So when you stand at the bedside and tap that patient's knee with a reflex hammer, you are diagnosing a rare autoimmune error, while simultaneously confronting the direct legacy of the 1976 immunization program. When medicine acts under total uncertainty at a national scale, a few people pay the physical price to guarantee the protection of the millions.